Thank you very much indeed. It's a real pleasure for me to be here today. I want to, of course, thank Dante Galliani and Sharmila Souza, but I'm sure many other people are also responsible. I'm particularly pleased to represent King's College and the collaboration between this institution and King's in London. I think we have a great deal to learn from each other, particularly over the question of the humanization of medicine, which is a complicated and difficult question. The case that Dante has referred to is from the Lancet. It's actually a very difficult case. Don't worry, first of all it's in English, but secondly it's a very difficult case, and I'm going to explain it as we go along. I chose a difficult case because I wanted it to be medically modern, medically challenging, and I hope that I can explain it to you as we go along. The title of my talk today is Narrative Medicine and the Humanities. Narrative is the form in which concerns about health are framed and discussed by patients, their friends, relatives, and by healthcare staff in clinical conversations, presentations, medical case reports. Narratives arise when someone else tells someone that something happened. It may concern feelings, sensations, thoughts, moods, arising from experiences which are lodged within the interior subjective realm, although the interior subjective realm has personal, sometimes physical, and interpersonal effects. So although it's interior, it can be sensed and appreciated between people. It also concerns much more external, directly ascertainable realm, such as the body structure that Ruth talked about this morning. Changes in structure, function, and individual circumstance. And what's interesting about clinical histories is that they bring together phenomena from these quite different experiential realms. I'm going to give an outline of my talk so that you've got a map of where I'm going, and I will then summarize my talk at the end in terms of this map. So I'm going to be talking about what is narrative, but I'm also going to be talking about the potential power of narrative in medicine. I'm also going to be addressing the question of what is narrative medicine and what isn't it. I want to talk a little bit about narrative variety in clinical cases, how the clinical case is constructed in different forms. I'm then going to move on to the question of what is the relationship between narrative and the humanities. The humanities and the humane and humanity in general. But I'm going to start with something that I take to be actually quite simple, which is the power of narrative in relationship to evidence-based medicine. And also the question of narrative and the skills that the humanities offer us for understanding the complexity of narrative, including narrative in medicine. This is a slide, you don't need to read any of it, I'll explain it. It's a search of the Cochrane database performed by myself this month, using the mesh terms which the Cochrane database uses, but which clearly relate to the humanities. So, for example, we have here narration, writing, autobiography, biography, and their definitions. And the Cochrane database in evidence-based medicine understands that forms of activity which we associate with the humanities may have an impact on health and well-being. And if we just take narration, we can find that there are 64 controlled studies looking at the effect of narration on human health, storytelling. And there are 5 systematic reviews of these studies. If we look at just one of these, which I've taken simply because it's recent, it's a randomized controlled trial of storytelling from the Annals of Internal Medicine published this year. It involves nearly 300 Afro-American people, mean age 54, half of them with hypertension, who were randomized to an interactive storytelling intervention which was developed by people from their own cultures in the United States with actors and storytellers gathering information about what stories mattered to these people and incorporating them onto DVDs. So that's the intervention versus continuing usual care, ordinary care, the sort of care that they were having for their hypertension, or not having any care at all. And the results of this study show that among the people with uncontrolled hypertension, blood pressure reduction favoured the intervention group after 3 and 6 months. The systolic and diastolic blood pressure. So the reduction of systolic was about 11 millimeters of mercury. That's a very significant reduction in blood pressure. It's as high as you would expect or want from any powerful drug, with a confidence interval that is clearly not near 0, so statistically and clinically significant. A diastolic pressure also of a significant reduction. Now, I said at the beginning, I think this is a simple effect of storytelling. We can only speculate how or why this happens. There must be psychological mechanisms. Perhaps it's related to relaxation, comfort, familiarity, enjoyment, general sense of well-being. What these scholars, what these scientists did not do was incorporate an oral history part of the study to inquire how the patients used the stories, what they meant to them, why they mattered. We don't know. That's why I call it simple. Of course, it's a complex intervention in medical terms. It needs qualitative analysis to understand it. I'm going to be talking this morning about the ways in which narratives depict aspects of lives in time, and how they express interpretation of what's thought to be going on in a situation. Narratives are communicated orally, gesturally, in discourse, in images. Sometimes narratives are hardly communicated visibly at all, as when we tell ourselves a story. A narrative is something much more than just capturing information and transmitting information. It has an unfolding structure which is layered with meaning. And that layering results in part from the strategy which the author, the teller, decide to use when they select, when they censor, when they use the extraordinary freedom which narration gives us to shuffle around constituent elements in a story so that we can configure the story in one way or another way. So medical narratives depict aspects of lives in time. They represent what is of concern, as I said at the beginning, from the inside, from first-person point of view, but also from outside, from the third-party perspective, from the perspective also of the machine that we heard from the introduction, the machine image of the human brain in this case report, and they express interpretations of these about what is thought to be going on. But the shape of a narrative is influenced also by pre-existent templates, by the shapes of stories which are handed down to us through culture, through history, through storytelling forms, in the form of drama, in the form of the sort of thing I'm doing now. I'm speaking to you, you're listening to me. What I'm saying has a shape. Roland Barthes, the French literary and semiotics theorist, signalled the extraordinary plurality of storied forms in human culture when he wrote, "Narrative is first and foremost a prodigious variety of genre, distributed amongst different substances, carried by articulated language, spoken or written, fixed or moving images, gestures. Narrative is present in myth, legend, fable, tale, novella, epic, history, tragedy, drama, comedy, mime, painting, stained glass windows, cinema, comics, news items, conversation. It is also omnipresent in medicine. But it's omnipresent in medicine in a fragmentary way. Rita Sharon from Columbia College of Physicians and Surgeons in New York has written very movingly about narrative and medicine. And she writes in her book, Narrative Medicine, that as a living thing, narrative has many dimensions and powers. The novelist values its creative force. The historian relies on its ordering impulses. The autobiographer redeems its link to identity, to personhood. What is clear, she writes, is that narrative does things for us that cannot be done otherwise. It structures novels, newspaper articles, letters. It allows us to talk about the world, to depict characters, to suggest causes, the passage of time, most importantly, to use metaphor to convey meaning otherwise elusive. As an instrument for self-knowledge and communion, narrative, she says, is irreplaceable. I'm going to talk a little bit about metaphor and how metaphor is built into the structure of stories in my next case. This is the case of a published medical report in the British Journal of General Practice, a journal with an impact in science and medicine. And it reads, Mrs. B was 84 years old when her general practitioner, her family physician, who had known her for a decade and a half, was asked to see her. Mrs. B had been widowed for 5 years following the sudden death of her husband, Jack. Her two sons had been a disappointment to her. Both were in and out of prison for criminal offences. The practice nurse had asked the doctor to see her after looking at her blood test results. Below, we show Mrs. B's multiple and compounding conditions and the results of her most recent tests, which sparked the consultation. So here we see Mrs. B's diagnoses. She has diabetes, hypertension, osteoarthritis, macular degeneration, and depression. And here are some laboratory results. Glycated hemoglobin, a measure of blood glucose excursion over about a 2-month period. Blood pressure, cholesterol reading, body mass index. And this is how it's laid out in the case, in the report. It's laid out as if it's in a medical record, although it's actually in a case history in a journal. The doctor rehearsed with Mrs. B the abundant evidence supporting interventions to improve all her biochemical parameters. There was evidence, the doctor said confidently, to support changes in her lifestyle. Mrs. B listened carefully to the doctor and then remained quiet for a moment. After a while she spoke. "Well," she said, "Jack's dead and the boys have gone." Now this account relates brief details about Mrs. B, including her biochemistry. The narrator is not the doctor or the nurse or Mrs. B. It's somebody else who's using the story for a purpose. It's a third party. The third party creates a sense of suspense, which comes to an abrupt halt on a dissonant note when it's revealed that Mrs. B and the doctor inhabit very different concerns and different worlds. They are preoccupied by different problems and different values. Each party to the consultation thinks and speaks at cross purposes, although this is not in the beginning apparent. Words such as rehearses cause readers to wonder whether the doctor is bored or on autopilot. And the term abundant makes us realize that the doctor is aware of a huge amount of evidence which will inform his assessment and recommendation for this patient. But, of course, in this report, no recommendation is forthcoming because a chasm opens up between doctor and patient, and this chasm is expressed in the pungency and the concision with which Mrs. B speaks. All the medical evidence in the world does not matter to her. She has other things on her mind which influence what she says and the way that she says it. And the way that she says it almost jumps out of the report. The report hints at Mrs. B's inner world, at her distress and worries, which appear to break out of the framework of a medical transaction. What Mrs. B needs, readers surmise, is a doctor who is not in thrall to biovariables, but one who temporarily can turn away from the sifting of evidence, however abundant that is, and turn attention to just how lonely and hopeless this elderly widow feels. Now, narrative medicine is not, in my view, a new paradigm which seeks to supersede or license doctors to reject or dispense with scientific medicine. But it's a practice that recognises that storied forms and fragments lie at the heart of clinical work. It differs from attentive listening, which is a favourite term in modern communication studies in medicine, which means hearing cues and hints which indicate that there may be something else beyond what has already been acknowledged, which is troubling somebody, which is troubling a patient. But like attentive listening, narrative medicine pays special consideration to the meaning of words, word order, intonation, non-verbal utterances, pauses, silence in the consultation. Rita Sharon has developed a reading theory of the clinic, which likens the patient to a complicated teller or a text, and the clinician to an expert listener, reader, who deploys what she calls narrative competence. What she means by narrative competence is the skill of recognizing, absorbing, interpreting, and being moved by the stories of illness. In Sharon's formulation of narrative medicine, the practice is not just a set of cognitive or interpersonal abilities, it's a moral and emotional responsiveness, a form of human attunement which clinicians share with oral historians and skilled ethnographers, who also perform close listening and reading activity. Quote, "When doctors or nurses listen to patients in this way, related to what psychiatrists call listening with a third ear, they will ask themselves readerly questions. Why is she telling me this now? How come, as the doctor, I'm feeling irritated or distracted or sad as I listen to her? How come she started with the end of the story and told it backwards? Why did she leave out the chest pain until the very end? Why has she included her sister's accident in the story of her bellyache?" As with attentive listening, narrative medicine poses questions that bear on the patient and the doctor relationship and their feelings. It recognizes that the objective, impersonal and universal view to which science aspires does not always provide the sufficient foundation, even when it's augmented by sociology and by interpersonal insights and by ethics, to provide and forge a comprehensive understanding of clinical phenomena. Narrative medicine counterbalances the explanatory drive of clinical science to account for the medically complex in terms of simple elements, biovariables, to collapse experience of predicaments into ill health and quantifiable and controllable parameters. The physician and philosopher Raymond Tallis argues that for someone suffering from renal disease, intractable moral and epistemological difficulties arise from believing that a discoloration of one's days, a pruning of one's future, and a loss of hope translate directly into a blood urea concentration of 50 millimoles per litre. As Tallis puts it, the experience and human significance of illness are simply not science-shaped, unquote. Narrative medicine fosters a double vision, not only an eye to monitoring raised urea, potassium, declining glomerular filtration, but also minute attention to the idiomatic accounts of human experience, understanding renal physiology and biochemistry, and the biographical and existential elements of life lived with kidney disease contributes to understanding the nature and the quality of life lived with that condition. Narratives arising from the medical gaze crisscross those arising from patients. Each is a part of clinical medicine, but it requires different sorts of apprehensions and understandings, which are both represented in clinical medicine. Long after the terms narrative medicine or narrative-based medicine were coined, the ability of clinicians to reconstruct the history of a complaint was highly prized. The most important difference between the good and the indifferent clinician lies in the different amount of attention paid to the story of the patient, wrote the Oxford Professor of Medicine, Safakar Bazard, in The Lancet in 1933. History-taking is the greatest art in medicine. Generations of clinical teachers have acknowledged its importance and have tried to pass on the art to their pupils, unquote. The words of Robert Platt, a future president of the Royal College of Physicians in London in 1947, in The Lancet. Since when, of course, the pivotal position of the history in diagnosis has been confirmed in many studies. In fact, though, the term narrative is used in the 18th and 19th century to describe complex and difficult stories. So here we find, for example, in the mid-18th century, a narrative of the effects of a medicine discovered by Mr. Keyser on venereal disease. A narrative of the extraordinary effects of a medicine, 1767. A narrative about the Great Plague in London, 1769. In the medical literature, a clinical case, an extraordinary narrative, 1832. Or on a proposed remedy for epilepsy and other afflictions, narrative of 2 visits to the hospital for epileptics in France, 1862. Although narrative medicine can make no claim to early notice of the place of stories in clinical work, I believe it takes new account of them by linking clinical practice to other fields of inquiry, such as narratology, psychology, ethnography, trauma studies, and oral history. And the reason why this is important is because these disciplines place different weights on the informant's accounts, and they attend to different terms of the way that the accounts are framed and constructed. All disciplines that study narrative test narrative. They don't necessarily take the informant's account as the truth, because they all understand that narrative is a constructed shape. It's a human artifact. It is not a product of nature. Narrative medicine widens the angles of clinical gaze, and it increases the depth of the clinical visual field. In effect, patient narratives are valued not only for the provision of information, which assists in formulating diagnosis and treatment, but in their own right as critical components of patient-centered humanistic care. This is just to show you that patients are using the term narrative about their own medical condition in the mid-19th century. This is the frontispiece from a story published by a gentleman, John Percival, about his episode of mental illness, and it explains not only what he thinks the causes and the nature of the illness is, the insanity, but also the way he was treated by his doctors, and it is a critique of the way he was treated. So this is mid-19th century. One of the most famous proponents of evidence-based medicine recognizes the importance of story. Of all the diagnoses that ever will be made, most are made during the history. Even when patients are referred to specialist centres, attention is focused on the key clinical enactment, the patient's story. So this is something that EBM recognises too. And I think it's very important that we don't see a big conflict between narrative and medicine, humanism and medicine, and science and medicine. We see where the overlaps exist, and we make the most of those overlaps. A story is not just a jumble of information. It's a highly ordered construal. Let's talk about this case in The Lancet of 2005. Let me tell you a little bit about this case. This is how the case starts. A 39-year-old right-handed community nurse presented to us on the neurology ward in April 2005. This case comes from Newcastle in the north of England. She had appeared subdued before starting the afternoon shift, and when asked, she could not recall her home address. The nurse's symptoms had begun 48 hours previously, when she woke with a bitemporal headache. That means a headache on both sides. Her vision then flipped 180 degrees, so that all images appeared inverted. She was able to crawl back to bed, and on waking 6 hours later, her vision had returned to normal, and the headache had subsided. She continued her engagements over the weekend. So what's happening here? We have a 39-year-old right-handed nurse. The right-handedness is mentioned because that's a sign of cerebral dominance.